I'll be talking about a presentation titled Scaling HIV Access to High-Need Populations and Locations, and I will specifically zero in on what we are learning from phase 1 with the implementation of the United PSI project. First of all, let me talk about why HIV self-testing for Malawi. As a country, we have made tremendous progress in identifying people living with HIV and AIDS. Almost 73% of these people have already been diagnosed. So the question is, why are we still interested in HIV self-testing? We know as a country to move towards 90% with this progress, it will be still challenging, so we need multiple approaches, and HIV self-testing is also one of the potential approaches that will actually get us to 90% of the people living with HIV in Malawi. And the second reason, there are pockets of the population, like key populations, men and young people in Malawi who still have multiple barriers to access HIV testing in the conventional services. For instance, the young people 15 to 24 years, it's only 53% of them who know their status. So we still have some work to do to reach out to young people, and self-testing is really promising in that direction. And also our strategic plan specifically mentions self-testing as one of the strategies to accelerate identification of people living with HIV in the country. And the country wants to test and adopt models that are actually working. So this is in line with our strategic goal as a country to achieve the 1990 targets. Now, the models that we have implemented in phase 1 were specifically to answer the question, is that the best way we can distribute HIV self-testing in the country to reach the populations that we wanted? So we are testing a number of models, a total for 5 models in phase 1. Of course, 3 of the models we have just started this year, and what I'm going to present here and the lessons we're learning is much of the CBDA model. So there are 4 populations that we're targeting. In the general population, there are actually 3 populations that we're trying to target. The rural population, using the community-based distribution model, and we also wanted to target the urban population, and that one we're using the private provider in a social franchise, which PSI is working in the country. And recently, we wanted also to target the urban population using the workplace. This one we're about to start, so I'll not talk about that in this presentation. We're also targeting the young men using VMMC mobilizers, and the specific reason why you're trying to do is to the link between testing for young men and also access to VMMC, like improving access to VMMC. And we are also targeting female sex workers, using female sex worker PA educators. And we're working with a local organization called Pakachere that has platforms to target female sex workers. The target that we wanted to achieve in phase 1 is to distribute 171,054 kits, and 73% of those kits were to be delivered using the community-based distribution model. Here I'm just showing you the startup activities that the country took to start implementation and testing these models. We were supposed to really identify where these target populations are, so we did a mapping exercise, identification of the people we're going to distribute to train them, community entry activities and demand creation activities. We also to translate the IFUs, the IACs and the job aids so that the distributors and the targeted populations could be able to be engaged and use the kits correctly. We started offering self-test kits in June for a 3-month pilot, and from September we scaled up to all the districts and the target populations that we wanted to reach with the community-based distribution. And then we developed also the M1D system, the supervision that we would do to understand what is happening, and also the supply chain monitoring system that is around there. And we are doing ongoing evaluation and learning from the implementation to understand what is working and what is not working, and what we should take in phase 2, and also the scale up for the country. Now, I'll show you what we are learning from the implementation data. First of all, who are we reaching in terms of first-time testers? Overall, in the country, 26% of those people who have already used self-tests are first-time testers. If you can see across the different models that are there, you can see that the majority of first-time testers are being seen through the VMMC, but that is area data. What I would want you to look at is more the community-based model, because that one we have implemented for 6 months, and 26% of the people who took up the self-tests and used were first-time testers. What about reaching men? In Malawi, 49% of the people who use the self-test so far are men. And what we are learning so far from implementing the CBDA model, we are looking at the 2 approaches that we took. The door-to-door approach, where we did not find a lot of men, and the more targeted approach, where we're trying to reach men from their space. For instance, I'm just giving you an example from one community where CBDA moving door-to-door could meet fewer men as compared when he targets them at their entertainment places. The communities that we are targeting in Malawi, most of the men are not working like in the urban settings, but they do their livelihood in different areas like trading centers. So we train the CBDAs, and they're doing more targeted distribution to ensure that we are reaching men. So we're trying to take these lessons as we're going to phase 2, so that our community-based distribution will not just be a door-to-door approach, but it's a more targeted, reaching out the population that we wanted to reach. You remember I said one of the reasons why we are adopting self-testing in Malawi is also to reach young people. I'm just showing the gap in terms of testing, as I've already indicated. Now, what are we learning from distribution of self-tests? 50% of the people who took up the self-tests, like 16 to 24, were young people. So this is telling us that if we adopt and scale up self-testing, we could reach a lot of the young people that we're failing to reach with the conventional testing. So this looks more promising. As we're scaling up to phase 2, we'll be considering this element and targeting the young people, as you can see from here. In terms of case finding, this is what we are seeing from case finding. Overall, 5% positive cases across the model. That's the yield level that we have seen so far. But if you look to specific models to see, looking at the social franchise, the VMMC, the female sex worker, the CBDA model, of course the other model are recently introduced. So we are excited with how things have started, but we'll keep on monitoring. But now the CBDA, which has been implemented for quite some time, is telling us the level of yield we can still get from implementing this, like 4%. So it's between 4 and 5%. When we are starting, the level of 8%, and as we are progressing, it has averaged 5%, 4% moving forward. This is not the hard nut to crack, but what is more promising in here is that linkage is happening, only that is happening outside our monitoring system. And I was reflecting on the discussion that started this morning, our interest, our need to know what is happening versus what the clients, the people using the self-tests want. the linkage data that we are capturing looks low, but when we're trying to understand what is happening, it's like the people using the self-test, they don't want to be followed as such. So they're linking outside our monitoring system, and they still accessing ART. And we're trying to reflect on that one to see what we can do in phase 2 as we're moving with Scale Up. Thank you very much.
Thank you very much, Richard.